Assalamu alaikum wa rahmatullahi wa barakatuh. So this is the second and last lecture I'm going to be giving to you as a flipped classroom lecture. I would appreciate your assistance and attendance of or watching the whole video. So the lecture is primarily about restoration of endodontically treated teeth. So endodontically treated teeth or root canal treatment, does that cause or make the teeth more brittle than vital teeth? So this is a thought that used to be in the past that RCT teeth are more brittle. Brittle means if you, like glass, if you hold it against something, it shatters. This is brittleness. So are they more brittle because of the dehydration caused by the presence of no dentinal fluid? There is no pulp, so there is no fluid inside the tooth. That's what it used to be taught, because many teeth used to break after root canal treatment. So, but recently we understand that the cause of those fracture is not related to the moisture content, because with new evidence told us that the actual moisture difference between vital and not vital teeth is not significant. So, are there any changes in the physical and mechanical properties between vital teeth and root canal treated teeth? I mean, if they are breaking, the RCT teeth, especially the posterior teeth, are breaking, having more fracture rates than vital teeth. Is it because we know that's not because if they're more brittle, so is it because they have different physical and mechanical properties? Again, they found that there is no change in the modulus of elasticity between vital and non-vital teeth, or vital and root canal treated teeth. There's no difference or no change in the fracture toughness. But what was different, or let's say the root canal treatment itself, decreased the stiffness only by about 5%. What actually caused the problem, as you do an occlusal cavity, they found that the stiffness decreased by 20%. Again, when you have an MOD, which is a big cavity, you find that the decrease in stiffness is significant. It's about 63%. So root canal itself, only the root canal itself, the mechanical preparation of the root canal itself, does not affect the tooth mechanical properties, and again, as we said, the brittleness of the tooth. So why everyone is concerned about root canal treated teeth, and why do some of them actually fracture more? Because root canal treated teeth, how did they end up needing to have root canal treatment? There was a significant reduction in strength because there was reduced amount of tooth structure, because the remaining tooth structure was reduced because there was a lot of things happening, caused the tooth to become non-vital and needing a root canal treatment. What are these things? Okay, a large caries, a large filling, a large access cavity. All of these together, or some of them, will reduce the amount of tooth structure. Just like what we said here, a large MOD will decrease the stiffness and will reduce the remaining tooth structure. These together will reduce the strength of the tooth. Okay, so this reduction there will be too much of a filling and small tooth. So at this stage, the tooth becomes very, very weak and prone to fracture. So that's why root canal treated teeth, we treat them differently, because they are different. Not because of the root canal treatment itself, but because probably what has led it to become root canal treated. Also, proprioception and pain threshold. This is a fact. Like, if someone doesn't have a feel no pulp, and remaining. So basically, this will cause the tooth to feel less pressure. So basically, non-vital teeth can tolerate more pressure and more higher pain threshold when you load them than non-vital teeth. Meaning, if you have a tooth, let's say lower right 6, and it is non-vital, and you have on the other side a lower left 6 and it's vital, so you will tolerate pain with pressure on the left hand side, which is the vital tooth, much sooner than the one which is non-vital on the lower right 6. So you are applying so much pressure on a tooth and you're not feeling it. So that can cause fracture and problem. And for this reason, why do we restore them? And for this reason, we have to restore them properly. Not only why to restore, but properly restore them to protect the reduced amount of remaining tooth structure from fracturing. So you don't want this reduced, prone to fracture amount of remaining tooth structure to break, so you properly restore it with the right restoration. This will enable the tooth to go back to function. So these together, but also in addition, you have done a beautiful root canal treatment that have, if you fill it properly, you will protect it from fracture. So you want this to be maintained, and to do that, you need to maintain a coronal seal for your RCT, which is done with your restoration. So the strength of endodontically treated teeth is related to the amount of dentine or tooth structure remaining. So how do we restore them? Now, how to restore them, it's a different story in the anterior than the posterior. Why? Because anterior teeth have relatively a tiny, small access cavity. This will not cause a lot of loss of tooth structure, so the fracture resistance is relatively not changed. Because of that, simply remove the GP or the gutta-percha up to the cemento-enamel junction when you have a small, not much of tooth structure remaining, something similar to this tooth. So you do the root canal treatment as normal, remove the restoration up to the cemento-enamel junction somewhere here, seal your gutta-percha with glass ionomer, then fill it with a bonded restoration, which is just a filling, a normal composite restoration, and that's it. You don't need to crown, you don't need anything. This is in the situation when you have such a tiny access, maybe with a class 3 or a small amount of loss of tooth structure. Here, the tooth still maintain a large amount of tooth structure that you don't need to do much other than a composite restoration. But when we have such a thing, sorry, this is a wrong fit. Let's remove that actually now. So this is the filling I'm talking to you about. So remove to the cemento-enamel junction, seal it with a tiny bit of glass ionomer to always protect the, which is a very good habit, to protect your hopefully everlasting RCT, and then a composite filling. Now, it's a different story when you have such a thing, badly destructed anterior tooth. In this case, you will require to do, which we will talk about later, post and core, and an indirect restoration, a crown. This is a different story. Okay? But most of the cases anteriorly, all what you need, I mean, from here to here, you can compare that. The difference is the remaining tooth structure. So if the tooth structure is remaining is a lot, then all what you need to do anteriorly is just a simple restoration. Now, posteriorly is a different story, completely different story. Posterior teeth are more, endodontically treated posterior teeth are more complex than anterior teeth. And the reason is the load. the axial stress. So any tooth beyond the canine, which is like old posterior teeth, they will receive axial load going this way towards the long axis of the tooth, more pressure this way. They will have a lot of pressure and stress under the cusps. And they probably have a lot of, they are the chewing teeth. They are the teeth that you use to do most of the function when you are doing the chewing and eating. So because of that, and also when this is accompanied by caries, as we said, and defective restoration and loss of a lot of tooth structure, you will and reduced pain or increased pain threshold, you will find that these teeth get fractured much more frequently when they are root canal treated, just like what we were talking. So as a rule of thumb, to have a posterior tooth, which is a premolar or a molar, which is root canal treated, to have it last longer and service longer in life, it requires a indirect or cuspal coverage for all the cusps. It requires restoration of cuspal coverage. Let me say this again. So any posterior tooth which receive a root canal treatment, okay, by default, if you want it to last longer, you require to provide it with a cuspal coverage restoration. What is a cuspal coverage restoration? A cuspal coverage restoration is a restoration which could be a direct restoration like a composite. You just have to remove the cusps here, reduce the cusp, and then do it as a composite like this here, reduce the cusp here and do it as a large extensive composite. Now this will work, but not for a long time, okay? It will be less, it's not going to be, maybe a medium term restoration. But a cuspal coverage by indirect restoration, like an onlay, which is a partial coverage, but here you did a cuspal coverage for the teeth, or a full crown, these two indirect restoration will be able to provide the tooth, posterior tooth, with a longer term better prognosis. So simply, in another word, a tooth, posterior tooth with root canal treatment provided with a cuspal coverage, preferably indirect. So either onlay or a full crown, as simple as that. Now, before you do a restoration or a crown on a tooth, a posterior tooth, for example, or a root canal treated tooth, what are the things that you need, even for an anterior tooth, what are the things that you need to take care of or check? You need to take an X-ray and assess the quality of the root canal treatment. Now, and the health of the surrounding tissue. Now, be aware, if the obturation is short, look at this photograph or X-ray, and no apical pathology you can see here, and this was done, let's say, 10 years ago, would you proceed with a crown? If this tooth require a crown, would you proceed with a crown preparation? Let's say that this is all opposed, for example. Now, everyone have a different philosophy. In my opinion, the whole point of having a root canal treatment is that you have cleaned the canal system and you have provided a radicular seal that allow the apical region to heal and return it to the health stage. So in my opinion, If you have it short and you were able and it satisfy all the other criteria, which we will be talking about here, it actually did its function. It's healthy. So, in my opinion, you can crown this tooth safely. Okay, if the patient refers to you for with an RCT made, for example, 3 months ago, and it was told to you, please do an apical, and there was a massive apical radiolucency, for example, like this one. This was done RCT, and you can see this massive RCT, massive apical radiolucency done, for example, still retaining, and the RCT was done 6 months ago or 3 months ago. The tooth is asymptomatic, for example. Will you proceed with RCT? Let's say it's 6 months. Now, the question that you have to ask here is that, where is the previous X-ray? Because look from here to here, you have a great improvement, a great healing in this region, and sign of healing in this region. And when it was left longer, complete healing was done. In another word, when you see an RCT or one X-ray at a time, even if it was large, this is a one picture or a one record that you have to compare it to a previous record to give you an idea of, it could be the other way around. You could have a tiny apical radiolucency, but 3 months ago, that tiny apical radiolucency was not there. So this is a sign of an infection. So one X-ray does not give the right information. You always have to compare it to a previous X-ray. Now, before restoration, you have to be sure that there should be no pain, no tenderness to percussion, no tenderness to palpation. There should be no swelling of fistula, okay, or a sinus tract, no exudate, no pus coming out, no periodontal deep pocket or endoperio issues. Access should have been sealed. In other words, that when you received it, the filling is not missing, and the RCT is exposed to the oral cavity, because I wouldn't restore a tooth if there was no coronal seal or a leakage and it was open to the oral cavity and saliva and bacteria for a long period of time. In my opinion, maybe 3 weeks is after that I would refer for a new RCT because there is a leakage now. All caries and restoration must be removed, okay, to allow for the assessment of what's remaining to structure and the decision making of what's the core that's needed. Before restoration, care should be taken to consider what's the length and width of the root, okay? Because if you don't have enough length and you need a post, then maybe this tooth is not restorable. Care should be taken to have 2 millimeters of tooth structure above your future margin. This is what we call ferrule effect if you are planning for a crown. Let's look at this picture. Maybe we should talk about this first. What is a ferrule? Ferrule effect. Ferrule is the 360 all around the tooth, ring of cast. So when you put a crown going this way, okay, it would be the cast. It's going to be the metal. It could be ceramic, but anyway, it's the restoration that encircles and holds the tooth, okay, above the finish line. So if we put a core here, ferrule is not here. It has to be related to tooth structure. In another word, or a simpler explanation of what is ferrule, it is the amount of dentine from the height of the remaining tooth structure to the finish line. This is ferrule. Why is ferrule important? Okay, so let's have a look at this picture. There is no ferrule. Look here, ferrule is this area from the margin to the height of remaining tooth structure. This is called a core. If we have zero ferrule like here, so between the margin and your core, there was no ferrule, no remaining tooth structure. You put just a post and core and a tooth. You apply pressure here. There is nothing holding the tooth. Pressure going like that, the tooth is going to break. Now look at this, or even here. Here you have a long ferrule. You press, apply pressure or function in this area, and the crown is hugging and holding not only the core, like this case, but some of the tooth structure. So when you apply pressure here, this will take part of the resistance, and this will not be moving, applying pressure. So ferrule provide bracing or encasing of the tooth, so this will provide less lever. There is no lever force, less wedging effect, and less lateral forces. So here, when you apply pressure here, this tooth structure will protect the movement of this. So less fracture. So ferrule, how much ferrule is gonna give me less fracture or less or more preferable physical properties? You need the height of the dentine collar or ferrule to be ideally 2 millimeters, minimum 1.5. It should be as parallel as possible, this wall and this wall. The width of each area of ferrule should be a minimum of 1 millimeter. The ferrule extension should be, so you need 1 millimeter of thickness and ideally 2 millimeter of height, 360 all around. So you did the ferrule, and you know that the tooth height is not enough. Your ferrule gives you part of the tooth structure, and the rest will be your core, which is attached to the post. So what's a post and what's a core? Post. Post and core can be one part or they can be two parts. But what's the post? This is one part, one piece, and this is a post with a different material core. They are attached together mechanically or chemically, or together, or chemically and mechanically. The post, regardless, is a dowel. Dowel, wetted. Why do we need it? Because there is a lot of tooth structure. So I am gonna gain by placing a wetted or a wet dowel inside the canal. I'm gonna gain some what's the word? I'm gonna gain some resistance and retention to hold extra core or material, so I can capture and hold the crown. So let's do this again. Post is a dowel that extends and fits into the canal system after you do a post preparation, and it becomes like a radicular restoration, and its only function is to retain a core, because there was no enough tooth structure to hold a core. So you actually use this and to wedge the canal, so it's holding your core. And what's the core? It's the material that replaces what was significantly missing. So does the post strengthen the root? And do we put it because we want the tooth to become stronger? No. The actually post weaken the tooth structure because you remove from the tooth or the root inside the tooth to give space to the roots, to the post. So actually, post weaken the tooth. It does not make the tooth any stronger. But why do we use it? Why do we place a post? Because we need it to retain a core. When do we need that? When you have too big access cavity, large caries, tooth wear, trauma, for a root canal treated tooth that no longer you can place a core, because the full core is gonna a normal core, you need a lot of tooth structure, so you fill it inside the tooth. So when you don't have that amount of tooth structure, okay, if you put a post, it's gonna fall off because the tooth is no longer enough tooth structure to hold and contain a core. Because of that, you have lost a significant amount of tooth structure. Because of that, we need a post only to retain a core and not because we wanted to strengthen the tooth. We needed to hold the core and because we want to place a crown. So basically you place a post to retain a core, you place a core to retain or to have a good foundation for your crown. We do not put post unless we have to because it weakens the tooth. Okay, so we determined that some teeth needs a post. How do you place a post? This slide is one of the most important slides in this video. Post preparation. How much is enough, what to do, what not to do. So you require to leave gutta percha 3 millimeter in bare minimum. I would not recommend you to do 3 millimeter. Please do your minimum as 4 to 3 or 4 to 5. 3 is bare minimum, and if you are going to calculate to 3 millimeter, you might remove more and then you lost your apical seal. Why do we leave gutta percha? Because it's apical seal. 3 millimeter of apical seal is just enough, so do not do 3 millimeter, please. I would consider 4 millimeter is the bare minimum. 5 is the ideal. Try always to aim for 5. So, how much post length? In my opinion, try to go as long as possible and leave 5 millimeter. Sometimes you have a curvature, so not beyond the curvature, and that might leave you more apical seal. You have to go as long as possible, okay? But the minimum is equal to the crown height. So this is the crown height. Let's say this is 10. If this is 10, then your post from here to here has to be at least 10, if not more. It has to be ideally 2/3 of the root. So if from here to here is your root, try to have 2/3 of the root length. Very important also is that your post crown ratio is 1:1. We said that. It's the same as saying the length of the crown and the length of the dowel or post are at least equal. If not, the post is longer. So the post can be longer than the crown but not shorter. In molars, do not extend the post beyond the orifice 7 millimeter. Otherwise, you might have perforation. These are the principles of having the post length. How much you should drill and remove from the gutta percha to have the post preparation. Post width, minimum as possible. Now, when we are talking about width, it's this. Try to be as minimum as possible. Okay, do not exceed 1.2 millimeter. Okay, the width, what is the smallest width of the tooth is here. So add the tip of the post. Calculate that the minimum thickness all around your post has to be 1 millimeter. So, or preferably 1/3 of the root diameter. So 1/3, 1/3, 1/3. So dividing 1/3, 1/3, 1/3. In this diagram, this is smaller than 1/3. but ideally should be one third, one third, one third. If you can't do that and you want to do it more than one third distribution, then just leave a minimum of 1 millimeter thickness here at the tip of the, because as you go this way coronally, the thickness is going to be more. This is the critical area. Okay, how to prepare the post space? As we said, 3 to 5, I would say 4 to 5 millimeter of gutta percha should be left at the apical part. This is because you have lateral canals in that area. You want to provide full apical seal. Retention of the post increase with the post length. So when you have short post and you press it like that, even if you have enough for rule, it is short. So there will be some lateral forces and more, it will be more prone to fracture because there is more stress. A longer post, you will have better retention, less lateral stresses, less fracture. The diameter going longer will improve the retention. Going wider will not have much influence on the post retention. In molars, as we said, do not exceed beyond 7 millimeters because probably you will have a perforation. Do not exceed the width in any tooth, okay, beyond 1.5. Large diameter post like 1.5 will significantly increase root fracture. Okay, what is okay, in width, we said you have to try to keep the width as much as possible, as wide as possible. So just removing the anatomy and leaving as much dentine, this is a theory called the conservative theory, but that can give you a very thin post. Sometimes it's not possible. Other theory, preservatives, they advocated to remove as much as possible, leaving 1 millimeter, as I was telling you, which is the bare minimum width-wise for the post. The proportionist, which is realistic, is leaving 1/3, 1/3, 1/3 of at the tip. Always we're talking about the tip because it's the least of the width of the post and the root. So 1/3, 1/3, 1/3 is a good practice, but leaving 1 millimeter is the bare minimum, is acceptable. Now, do not use more than 1.2 millimeter diameter because it was found that if you do that, most of the canals or the teeth width, when you leave 5 millimeter or the required apical seal, doing it more than 1.2, you will have a problem. You will have a perforation or very thin dentine wall. So it's very important. How can you measure these? You can calibrate your X-ray, okay? And you can calibrate. And how can you measure the 1.2, not to exceed? Is that when you are using Gates Glidden or piezo reimage, you can use the caliper and measure actually the head and do not exceed 1.2. So from 0.9 to 1.2 is what you can be using as a guide for you, but keep in mind that you must leave at the apex of your post 1 millimeter. How do you remove gutta percha? You can remove it chemically, thermally, or mechanically, which is the most common, like piezo or Gates Glidden. The problems with these: heat, fracture, perforation, instrument perforation. How do you classify post? Length, diameter, type, material design, by retention, active, passive, according to the material, according to the fabrication, custom made, fabricated, according to the surface, according to the side. For example, according to side, parallel sided or tapered. According to the surface, they can be smooth, they can be serrated, they can be threaded, they can be custom made, or you can use the direct pattern with resin or acrylic Duralay, taking a direct impression and then you cast it, or indirect, you take an impression into the canal and you send it to the lab, pick up impression, and you send it to the lab, and they can pour this and make a post and send it back to you as such. According to the retention, there is active and passive. You can read through these. I think you have covered these in third year. Regardless of the case, if they are passive or active, you have to use a cement to cement them. Active posts, a very important note about them. They are threaded. They are simply like a screw that you actually screw in and wedged into the canal. So you can use this is something we used a lot in the past, where you use a threaded post and you wedge it into the canal by screwing it in. It provides a great retention. You can use it as a short post because it's provide great retention. But guess what? When you're doing that, there is a high risk of fracture. That now it's well known that you have to try to avoid them, because you can break the tooth or the teeth. When you use active posts are very prone for fracture. Look, they shatter. Why? Because you wedge something into it. Now, according to the material, they can be metal post or base metal posts. When we're talking about, here it's mainly about indirect post when you send them to the lab. The metal, as in gold, they are the gold standard, but you can have base metal. They are cheaper, but they're not easy to adjust like the gold. Non-metal like the fiber post or like the ceramic post. Now, a note about fiber posts compared to metal posts. All fiber posts have good elastic modulus or similar elastic modulus to dentine, so they kind of flex with dentine, not like the metal. Metal has higher elastic modulus, so the tooth will flex and they won't flex. And guess what will happen? More catastrophic or fatal fracture with the metal post. Why? Because the tooth will fracture or the root will fracture, while with the fiber post, the fracture is mainly happens between the post and core or between the post and the tooth. So it's a better mode of fracture. So because of that, many people prefer fiber posts. Now, core material can be amalgam composite. Glass ionomer and compomer are not as frequently used because of their problems like high failure rate. Amalgam, like amalga core or other names for it, amalga core, amalgam core, amalga core, radicular amalgam, or what we usually call it as Nair core, after the person who have introduced it first in 1980, Nair, who advocated a placement of removal of 2 to 4 millimeter into the canal, okay, removal of GP, and then the different axes. So look here, 1, 2, 3 in 3 different directions, and then or 2 here, 1, 2, or maybe 3 at different direction, and then you fill it in amalgam. Okay, this 3 direction of a metallic alloy that sets later will give retention, okay, or gripping of this core, and you don't need to do a post. For this, you will need good walls of your chamber, and you don't need a lot of destruction of the tooth structure. This is called Nair core. Resin composite, it can be used like Nair core. It's first option when you want in the anterior teeth, and the reason is because you are going to be placing a ceramic, usually a ceramic restoration, so it will not show through as a metallic restoration. It's tooth colored. It can be used like amalgam, Nair core. Okay, it is preferable when you're using metal-free crowns, but it is, as you know, technique sensitive. It's sensitive. You have to use rubber dam, and if it's too deep, placing it inside, the depth of cure can be a problem. If you have not enough tooth structure and you don't have enough for rule, you have to bear in mind that you might need to do crown lengthening, okay? Um, if you're doing crown lengthening, you have to make sure that your root length is enough. Extrusion is another possibility if you don't have enough tooth structure, because if you, or you have to accept the poor prognosis and restore, extract or replace if you don't have enough tooth structure. Even because sometimes, even with, if you don't have enough tooth structure, you don't have enough rule, what you have to do is just extract. When do we place a post? We place a post when you have lost a lot of tooth structure. This is different when you have anterior versus posterior teeth. Teeth choice, when we have, it's a bit complicated than this slide. Molar, we know that crown is a must. Premolar, we know crown is a must when it's a root canal treatment. But the tooth usually in a molar, sometimes you have a lot of tooth structure remaining that can retain enough filling that you don't need a post. In this case, a core is enough and you can do your crown preparation or onlay preparation. Here, a significant amount of tooth structure has been lost, so you need to have a post to retain your post so that you can place your crown. So it depends. Placing a post in a molar, it depends. But with a premolar, unless you have something as such, which is quite rare, you have a small tooth and a large restoration. So usually because of that, you usually require a post, because there is usually a significant amount of tooth structure has been lost in comparison or in proportion to the small tooth size. And as we said, it's a posterior tooth, RCT, so crown is the right way to do the final restoration. Not the crown, you could say here crown or onlay, as long as it's coronal coverage. Anterior teeth, it's usually doesn't need a crown, usually doesn't need a post. Only if you have extensive tooth structure missing, then then you might need a post and core and a crown. So this is just a revision. You can read through that. How to assess the restorability. Assessing restorability is not easy. It's something that there is a lot of literature about it. There is a lot of variation. There is a lot of theories about it. But there are a few things which are straightforward. Let's go through some of these. When do we assess restorability? You have a tooth like that. You call me, Doctor, is this tooth restorable or not? So before, let's say this tooth is symptomatic and you plan to do a root canal treatment. So the right time to assess restorability is before root canal treatment, because guess what? If you do a beautiful root canal treatment and then you have noticed that it is extended subgingivally so deep, okay, that it is not restorable after all, then you have done root canal treatment for this patient for nothing and you have to extract the tooth. And this is a very, very bad situation for you and the patient. So from the beginning, when do you assess restorability? It has to be done before root canal treatment, well before. And because of that, any tooth that requires root canal treatment, you have to remove everything, all the caries, all the filling, all the fracture, and assess what is remaining, and only then check, is it restorable or not before you do the root canal treatment. To do that, you have to remove all the defects, all the caries, only then you can assess restorability. Can you assess restorability based on an X-ray or a photograph? No. Always, an X-ray is an underestimation and it's a 2D estimation. It doesn't give you the full picture. Photograph is not enough. You have to actually clinically examine. There are many, many factors about restorability. So it's a very difficult topic. You need to assess the patient clinically to assess restorability. Is the tooth restorable? As I said, this is a very difficult topic. But there are some area which is gray, which is this area, but luckily it is easier to say restorable, non-restorable in most of the case. The things or the problems that says this tooth is non-restorable, there are a few things are very clear. And once you have them, you proceed with extraction. And that's it. End story for that tooth. For example, if you have a vertical root fracture, that's it for this tooth. You have to extract the tooth. So there is no, in other words, there is a gray area which can be tricky, but the black and white is very easy to determine, and it can sort out for you a lot of issues. What are the things which is black? Tooth is to be extracted. What are they? Non-restorable teeth, vertical root fracture. When you have a tooth, how do you determine if the tooth is one of the easiest way is when you do a CT scan, but there are other clinical easy ways. You go with a probe, and the moment you have isolated one deep pocket in one point, you are most likely have a vertical fracture. Also, what we call it J lesion, J-shaped lesion, then you have a vertical root fracture. Also, when you have periodontal or any grade 3 mobile teeth, because of periodontal or another reason, these tooth have reached the grade of mobility. This mobility, why did it happen? Because there is no enough bone holding it. So because of that, you extract it. So grade 3 mobility, which is more than 2 millimeter in horizontal direction or any vertical movement, is considered grade 3. And that tooth, by definition, is difficult to be, and it has to be removed. Now, beware that to assess mobility, for example, this tooth here probably will have a grade 2 mobility. Why? Because this bridge of calculus is holding it together. So you have to give it a good clean before you assess mobility. Okay, that's important. Also, let's say this tooth here would have a grade, or here, this tooth here will have a grade 3 mobility. Now, this is tooth, there is no much, if it's the only tooth touching and the rest are not touching, this tooth will have trauma from occlusion. So it will have a magnified mobility. And the right thing to do is to do the good cleaning, remove the trauma from occlusion, and wait for 1 week and assess the mobility. If still 3, extract. If you have the same, if you have 65 or more of bone loss, the mobility might not be much, but it might be grade 2, but you see, and you know there may be something, the contact is tight and it's wedged. So if you have a lot of bone loss, 65 or more of bone loss, vertical or horizontal or a combination, that tooth is to be extracted. Extraction, 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 extraction. Pockets. If you have a pocket which is more than 7 millimeter, now this pocket, you can treat it. You can open this area and you can do JBR, guided bone regeneration, and you may save the tooth. I mean, you have to consult with your periodontist. So, but when I'm saying 7 millimeter that you cannot treat, or the patient is not willing to treat, then the tooth becomes of very poor prognosis and more or less require extraction. Perforation, again, perforation you can actually remove, and now we have material like biodentine or MTA that you can use and seal and successfully bring it back. But when you cannot treat it, or patient cannot afford, or the perforation is not sealable or not successfully sealed, and then the tooth becomes non-restorable. If you have root canal treatment that you cannot do, for example, the canal is fully very difficult sclerosed, or you have done it before and you still have infection despite doing the root canal treatment, or there is a post and you can't remove it and you cannot do the retreatment, all this causes is that from a root canal, from an endodontic point of view, you cannot get the tooth back to state of health, then the tooth becomes non-restorable. So these are very straightforward. Very straightforward. You can immediately, as I said, black or white. Here it's black. Root canal treated teeth, which are short, okay, and have a short root, and they have extensive tooth structure loss coronally. So because of that, they require a post. Let's do the calculation. This tooth, from here to here, your working length was 12. It's a short root. You can see there is resorption. It's a short anatomically tooth. Your crown from here to here is 7. Or let's say, sorry, it's 9. From here to here, it's 9. You need apical 4 millimeter. So your post has to be 9 and here has to be 4. So that's 13. Your root is short. So you cannot place a post, and because you cannot place a post, you cannot place a core, you cannot place a crown, so you cannot place a restoration, so you have to extract it. It's non-restorable. Okay? So you have, when you see a tooth where you need to put a post, you need to see how much is your root length. Okay? Because you need to do the calculation and see if it's feasible. If not, then it is non-restorable. Look at this one. Now, this tooth has a short, let's say that here you need to place a post. You did your calculation. Again, you can do apical, it's apical GP for 4 millimeter, and you can place a post successfully, same height as the, so this is restorable. Let's look at this. Now this is a tricky one. You have a small filling mesial distal and axis cavity and terribly short canals, roots because of resorption. Now, can we restore this tooth? Yes, we can. And the reason is you don't need the post. Although they are short, all what you need to do is a filling, and that's it. So be aware, this is different than that. There is a lot of tooth structure, and all what you need is just a composite filling. So the assessment of these is what made them of questionable or poor prognosis here is that they are short and requiring a post. Here we don't need a post. So all what we need to do is a normal filling. Now, when the case is related to caries, how do you detect should we remove or should we leave? As I said, X-ray alone is not enough, because if you can see it as such as caries, clinically the extension of caries is usually more than radiographically. So X-ray is a poor indicator. So you have to remove, to assess restorability, you have to do the following. Remove all the caries until you reach enough or sound tooth structure, and only then assess what's remaining and what is the extension of your margin. If the extension of your margin is very deep, subgingivally, 2 to 3 millimeter subgingivally, or you have radiographically 3 millimeter away from the, less than 3 millimeter away from the bone, so you are violating the biologic width, because we said just subgingivally 0.5 into the gingiva. Here is your subgingivally by 0.5 millimeter. So we said earlier in previous lecture, you have to extend maximum 0.5 into the sulcus. Here I am 2 millimeter under the sulcus, subgingivally. So what's remaining here is maybe 1 millimeter or 1.5 away from the bone crest. So I have violated the biologic weight. If I cannot do crown lengthening here and move the bone down, this tooth is not restorable. So how do you assess restorability? Is based on how much is the remaining healthy tooth structure and its extension. Remove all the caries, all the restoration before assessing restorability. Look at this one, root canal treatment with short clinical crown. This is another one. This is not related to the previous one. Now, if you have a root canal treated tooth, you will need ferrule. Okay? You need ferrule. For example, here, you need 2 millimeter of ferrule. Here you have, if you do a preparation, so you have 4 millimeter of ferrule everywhere. Here 2 millimeter, 2 millimeter, here 4 millimeters. Your minimum is 2 millimeters, so this tooth is restorable. Look at this one. You prep this tooth and you will find that here you have remaining tooth structure of ferrule is 0, 0, 1.5, no ferrule. Either do crown lengthening or extract. Again, look here. You do crown preparation, you have 2 millimeter of ferrule everywhere. This is root canal treated, so you can save that tooth. This one, subgingival caries. If you remove the caries, you have two problems, and it's root canal treated. You have two problems. You have violated the biologic width because the caries is subgingival. Either do crown lengthening, but if it's root canal, you need to do extra crown lengthening to get your ferrule. If you can't do that, extract, gone. Look at these ones. Preparation, root canal, all of 4 of them. Ferrule 0.5 everywhere, ferrule 1 millimeter everywhere, ferrule 2 millimeter, 1.5, ferrule very little. But what we did here, we did crown lengthening for all of them and gained enough ferrule for all teeth, place the post and place crowns. So if it was like that and I cannot do crown lengthening, most of them, which is this and that, probably will require extraction. But here you have saved them with the crown lengthening. So for that you need to analyze, you need to think. This is an example, root canal treated tooth. You have to, if it has an MOD, let's assume it has an MOD with a deep distal box. With teeth that had or requiring RCT, it's a must to have a ferrule. Okay, 2 millimeter ferrule everywhere, at least 1.5 millimeter of ferrule everywhere. If we prep the buccal surface of this tooth, we said you remove occlusal reduction, 2 millimeter for example. It is already 8 millimeter. Let's say it's 2 millimeter and you know that your crown height from previous lecture for a molar, you require 4 millimeter. So you remove 2 millimeter and you prep 4 millimeter, which is reaching up to the mesial box. This is the mesial side, this is the distal side. This is a root canal treated tooth. So although you have the right height, but you don't have any ferrule. Luckily on this side, the tooth is long and not for functional, not for height requirement, but for ferrule requirement. Don't stop here. Stop here equigingivally. Gain this millimeter, 2 extra millimeter as your ferrule, and your preparation is going to be all the way up to here. Yes, your preparation is going to be 6 millimeter in height, but you have gained your 2 millimeter of ferrule. It's a very different story on the left here, or sorry, the right, which is your distal of the tooth, where you have a large filling and significant loss of tooth, that the tooth here is 8 millimeter. So when you prep your occlusal height and you prep all the way to the gingiva, you have only a ferrule of 0.5 millimeter. What's the minimum that we require? 1.5. Even if we go subgingivally, 1.5 millimeter, which is allowed subgingivally, you will have a ferrule of 1 millimeter. Still not enough. So in this case, you have to plan and tell your patient from the beginning that this is tooth to save it, you will require either crown lengthening or orthodontic extrusion. Otherwise, you have to extract it because the tooth would be non-restorable. Thank you very much for listening to this, and I hope to see you this week to go through this lecture together and discussing few points. If you have any questions, please prepare them so we can have the most of this. Thank you very much.